In this retrospective study, we aim to look to the first sign of efficacy of EPO in VEXAS syndrome plus or minus MDS. So it was the data coming from medical charts for 5 university centers across France, and all the patients who have VEXAS syndrome plus or minus associated with an MDS according to the new classifications of the WHO, and we looked into erythroid improvement at week 16 and 24, like the definition of IWG 2018. And we also looked at a secondary endpoint safety, and more specifically adverse events of special interest in this disease, which is thromboembolism, because VEXAS patients do have high risk of VTE. So it was really important to see if we increase this risk in this specific patient. So we include 30 patients. I will not depict the clinical characteristics, which are very close to what we see in real life settings, and without any time, the result is mostly very close to what we see regarding the efficacy of EPO in MDS, even if they do not have MDS, which was about 30 to 40% of erythroid improvement at week 16 and 25% of erythroid improvement at week 24. So clearly very, very close to what we used to see with usual MDS. The other thing which was very interesting is that patients with non-transfusion dependency was more likely to respond to EPO compared to those who are high transfusion burden dependency. For example, for the non-transfusion dependent patient, 50% of them respond at week 16 and only 20% for the high transfusion burden dependent patients, suggesting that the more severe the disease is regarding anemia, the less likely the EPO will work. Regarding the predictive factors of efficacy of EPO, IPSS-R, IPSS-M wasn't predictive of response in these patients. The only factor that was predictive of response is like MDS, is the endogenous EPO levels at baseline prior to introduction. Patients with low EPO levels were more likely to respond, and it was the only variable that might affect the predictivity of response beside the transfusion burden history of the patients. Non-controlled VEXAS manifestation, even in patients with inflammatory or active disease, it wasn't at least on this very small series, but it wasn't predictive or response or no response in this patient. The other thing is that patients that do respond to EPO do not have a better or worse overall survival, which was pretty poor because the median overall survival was about 15 months, which is for this population not so much. And finally, we also explore the Luspatercept efficacy and safety as well in 8 patients in this cohort, and we see 60% of responders at week 16, which was sustained at week 24. So the patients that respond usually keep their response through time, and even if it was only 8 patients, this is a good signal for the Luspatercept as well in these patients, which were all of them prior exposed to EPO prior to start the Luspatercept. And regarding safety, we only see one VTA, one thrombosis during the treatment period, either and this patient who present a venous thrombosis was treated with EPO and not by Luspatercept. So if we want to address a very short conclusion, that EPO in erythropoietin in VEXAS seems to work, but like in MDS, mostly in patients with low risk features or low transfusion burden or non-transfusion burden patients, Luspatercept seems to also give good signs of response in this preliminary sets of patients, and for what we saw on this limited cohort of patients, but they do not seem to have an increased risk to do VTE or any thrombosis, even in arterial territory. So it was pretty encouraging, and we are looking forward to, we think that to move to prospective trials. I hope to at least try to be more, robust on the conclusion we can get on a retrospective study.